Good evening, delegates and friends. Thank you for joining Shield Connect. So today, again, we are back with the Icons series, Icon with Dr. Ritu Santvani. So today we have Dr. Rangina Laikanbam. Ma'am is from Nepal, and today she is going to take topic basic and advanced hysteroscopy. Before the session start, let me welcome our speaker as well as Dr. Ritu Santvani. Let me share my screen. So today's topic is basics to advanced hysteroscopy, and this webinar is possible due to Dr. Ritu Santvani on Shield Connect. So let me give a little introduction of our Dr. Ritu Santvani. Ma'am is obstetrician and gynecologist, sexologist, cosmetologist, and fertility specialist. Recently, ma'am has a new clinic, and ma'am is a founder and CEO of a 360-degree healthcare studio in Pune, as well as ma'am is director of Shamwell Women Clinic and PTBC. Ma'am is also co-founder of MAAM and board member of SCG. Sorry. So let me give a brief introduction of our icon of the day webinar. Dr. Rangina Laikanbam. Ma'am has done MBBS, MD from KU and DMIS from Keele University. And ma'am is a laparoscopic gynecologist and infertility specialist and consultant at Norwich International Hospital in Nepal. Ma'am has done MBBS from College of Medical Science Bharatpur for KU in 2006. Ma'am has done MD in Obstetric and Gynecology, College of Medical Science from Bharatpur KU in 2014, and diploma degree in gynecological endoscopy surgery from Kiel School, Germany in 2018. And presently working as a consultant in Norwich International Hospital in Obstetric and Gynecology Department. Ma'am has also worked as a consultant as an endoscopic gynecologist in Alka Hospital in Jawaharlal for 3 years and completed more than 1,000 cases of laparoscopy. Also worked as a consultant in Siddhi Memorial Hospital and Surya Binayak Kathmandu for 2 years, and also in Paropakar Prashutikara Hospital in Thapathali in Nepal. So I welcome Dr. Ritu and Dr. Rangina for today's webinar. So Dr. Ritu, I hand over the session to you.
Yeah. Thank you, Nishant. And thank you, Shield Connect, for providing the platform. Sorry, friends, I am still at my center, so not possible to on the video. In between, I will try. So a very, very warm welcome to our dear friend, Dr. Rangina. Friends, today we have reached to Nepal. As you all know, in this series, every week we are moving all across the geography. So today, my very dear friend, Dr. Rangina, we can say a queen of Nepal, is with us. She is a very dynamic lady, a very good doctor, a very passionate about the teaching also. So today she is going to discuss with us regarding the basic and advance of hysteroscopy. Thank you, dear Dr. Rangina, for accepting our invitation. So without wasting time, we are first going to start with her presentation, and later on we can have some questions and our chit-chat session. Thank you once again, Nishant. Yeah. And thank you, Chitra, too. Yes, over to you, Dr. Rangina.
Thank you so much, Dr. Ritu, for such a kind words for me. And thank you, Shield Healthcare and Nishanji, for giving me this opportunity to share some of my views about basic and advanced hysteroscopy. So before starting my slides, basically what I'm going to share today is my own experience rather than reading out the slides from my laptop. So before starting the topic, I would like to share a small incident which happened with me a few years back. I was in one of the conference and one of my junior asked me, "How are you, Dee, and what are you doing these days?" So I just said to her that these days I'm very busy in doing hysteroscopy. So the first answer which I got from my junior was, "What's there in hysteroscopy? It is just you have to put a sim speculum and then you have to hold the cervix with a Ellis forceps and insert the hysteroscope. So is it really that scenario?" So let's discuss today about basic and advanced hysteroscopy. We all know that usually when I even started about hysteroscopy, I thought it is only about the visualization of the uterine cavity, just to see the endometrial cavity, to see the shape of the uterus. But later, as I advance in this field, I realized that it's more than something more than uterine cavity. We can say it as a combination of vaginoscopy, cervicoscopy, and uterine cavity. So first, whenever we insert a scope, it's always my aim is to see the vaginal cavity. I still remember a case when Dr. Osama Sauki presented in one of the conference, a lady who was suffering from severe cyclical abdominal pain, and she has gone to multiple centers and it was not diagnosed, and she was suffering from cyclical pain, and there was no any ovarian cyst, any uterine mass, and in hysteroscopy, vaginal endometrial spots were observed, and she was treated, I think endometrial ablation, that endometriotic spots ablation was done. So it's very necessary to know what actually we are doing. So hysteroscopy basically is not about the uterine cavity, it's about vaginoscopy. We can see the cervix, whether there is any erosion, whether even if there is a presence of small polyp. So rather than seeing, it's about see and treat approach. So little bit of scenario in Nepal. It's very alarming stage even in Nepal, because hysteroscopy, there are lots of doctors who are doing hysteroscopy, but basically what is hysteroscopy? We should know that. Before touching the scope, we should feel and we should know that it is not only seeing the pathology, it is about seeing and treating the pathology. So compared to other modalities like transvaginal sonography, SIS, hysteroscopy is more accurate. We all know that to evaluate the endometrial pathology, it is more accurate, and endoscopic visualization within the uterus. About the blind intrauterine DNC, I really want to share one of my case, 65 years old, who came down with postmenopausal bleeding. She had done endometrial biopsy, which shows that there is no endometrial hyperplasia. There is the tissue doesn't have any significance of malignancy, but still she had another episode of vaginal bleeding. It was a postmenopausal bleeding. She came to our hospital. We did a hysteroscopic guided endometrial biopsy. And yes, when we inserted the scope, we could see in right lateral, there was a small endometrial growth type, and we just took out that small tissue, and yes, it came out to be an endometrial carcinoma. So how important it is for us to change our scenario, our practice today from the world of blind DNC to hysteroscopic world. So coming to this history, I would not like to take long in about discussing about history, because every one of us know about the history that in 1969, Pantaleone reported the successful removal of an endometrial polyp, and it was just because he didn't use any hysteroscope what we are using today, but it was just a hollow tube which he has inserted with an alcohol lamp and for a mirror for the light source. So talking about the indication of the hysteroscopy. So now there are many people who says that hysteroscopy is nothing. We just have to see the uterine cavity, and it's just seeing about the cavity and both the ostia, and even if it is like even if we see a septum, we can repair or we can do it later. But it's not in that scenario. Even in AUB, there are many doctors who has discussed that it is not necessary to go for hysteroscopic guided biopsy. Rather, blind DNC or a biopsy with PPLA is even better. So if we talk about AUB, It is not only about the endometrial biopsy. Even in AUB, if we detect a small submucosal fibroid or polyp, we can use a resectoscope and then we can remove the polyp. Even we can do a hysteroscopic myomectomy. So persistent abnormal uterine bleeding with a negative endometrial biopsy, of course, we can do a hysteroscopic guided endometrial ablation. In postmenopausal endometrial thickening, I have just shared my view about it. Endometrial polyp, I have talked about it. Submucosal myoma, yes. There are lots of studies which says that around 3 centimeter myomas we can remove hysteroscopically. But in my clinical practice, even my registrar has joined today with us, Dr. Ritu Subedi, and we have done even submucosal fibroid till 5 centimeter hysteroscopically, although we have done the case in 2 sitting. And uterine septum, it's very important. Till in Nepal scenario, recurrent pregnancy loss or either even in infertility, the most missing investigation which I have seen in my practice is, yes, it is hysteroscopy, because nobody we have attended lots of conferences where it says that we should not do torch test, but still torch test has been done. We'll be doing lots of investigation, wasting patients' money, karyotyping, everything, but the only thing which is missing out is, of course, hysteroscopy. So uterine Syneky-Eschermann syndrome. Yes, recently we had a case of Eschermann syndrome, but we could not repair that case because there was zero visualization of the uterine cavity. Even we put the scope from up laparoscopically, but we could not repair that case. In spite of that, about written IUD, apart from written IUD, I would like to focus on written fetal bones. Written fetal bones. I don't know about the scenario of India, but in Nepal, to have a male child is like priority, and it's a must for most of the families, even educated families. And in my career, I have seen more than 10 cases of patients who have done second trimester abortion and with written fetal bones, and we had removed those written fetal femur bones, skull, even scapula through hysteroscopic guided. Yes, sterilization. We all know that hysteroscopic sterilization, which I'll be speaking in the last slide. About the contraindications, it's simple. If we are preparing a case for hysteroscopy, we should, of course, rule out for PID. We should rule out vaginal infection. We should rule out pregnancy. Yes, if there is any history of recent uterine perforation, we should not go for that. Even cervical and uterine cancer, these are the absolute contraindication. Relative contraindication, we all know that if there is active bleeding, we cannot see the uterine cavity nicely, so it's not possible. Or either when there is extensive adenoma or leiomyoma, which is occupying the cavity more than 50%. So talking about the operating room and basic knowledge of hysteroscopy. So when we start hysteroscopy, it is very important for us to know each and every steps. Apart from each and every step, the instrument and the irrigation, what we are going to use, and the flow meter. It is very important because in your operating room, the nursing staff, the doctor who will be assisting you, it is very important that when they are assisting you, it is very important for them to guide you about the amount of the fluid used, to know whether there is any fluid deficit or not. Yes, we should always remember that a simple procedure can even cause a fatal complication in the patient. So air embolism, while owning the irrigation pump, we should be very careful that if the irrigation, we use ringal-lactate, RL, or either we can use, I think nowadays, many of us prefer to use bipolar. So bipolar, we are not using mannitol nowadays because unipolar, I personally don't prefer. So it's very important that while owning the fluid, they should not pass the ear while doing the procedure. We should always be very careful. The sisters should be very careful while owning the fluid and like if you're going to change the fluid, then it should be very careful that the bubbles should not pass through the uterine cavity. So about cost effective, I don't know how costly it is in India, but in Nepal, as it is in starting phase, it is, yes, it is of course a little bit expensive. And I don't do office hysteroscope, but there are many people in India, which I have seen in many of the, I don't know about other doctors in Nepal, but I don't think in Nepal we do office hysteroscopy, because there are few doctors who are trained in the hysteroscopy in Nepal. Talking about hysteroscopy, so let's talk about the instrument. So there was a time when we used hysteroscopy of 4 millimeter, and as I've already discussed, that it is vaginoscopy, cervicoscopy, and the uterine scopy. So it is a combination of these three. So now we know that we have scopes of 2.9 mm, and even mini scopes are also available with different companies. And with this, the help of this scopes, we can see through the high resolution telescope, we can see and we can visualize the vagina, we can visualize the cervix, we can visualize the uterine cavity. It is very important to know your instrument, the outlet, the inlet, the outlet, the scope, how to insert it, how to fit your instruments, how to fit your light source, and how to lock your instruments. Because I have seen in my career where people says, yes, I do hysteroscopy, but they don't know the parts of the hysteroscope. They don't know how to insert the scope. They don't know how to lock the scope. They don't know how to put an inlet that, and they don't know how to, even when we ask whether your hysteroscope nipple is working or not, it is, the water is passing by. So it is very important for us to know the instrument, what we are using, because from that only we can give the result. If we don't know the instrument itself, then we won't be able to do a good procedure. So as I have said, we should know about the light source. We should know what scope we are using, 30 degree, 0 degree, the diameter of the scope, and the light source, and the inlet, the outlet, fluid deficient. Everything is very necessary for us to know. So there was a time when we used to use, like, I have not seen in my career, I know 4 mm scope, but I have seen in many of the studies also that previously they used to use around 8 to 10 mm. This I have seen in cystoscopy. I have seen urologists using cystoscope, which is around 8 to 10 mm, but in my career, I have not seen anyone, especially my teachers, using 8 to 10 mm of diameter of hysteroscope. Talking about the distension media, I think all of us are nowadays, I use normal saline. So it's like we are not using monopolar nowadays. All of us know about the glycine in monopolar, high chances of hypotonic fluid overload. So many of us, even the companies who are bringing out the hysteroscope, they have stopped promoting about the monopolar electrosurgery. So usually I think all of us who are listening today also, all of us agree that we are doing a bipolar, we are using a bipolar, and we are using the normal saline and the oringulated. I personally prefer monopolar. I personally prefer bipolar with normal saline. So distension media, it's yes, the same which I have just spoken. This is a very important part. We should monitor preoperatively and intraoperatively. Very importantly, fluid management is very important, and we should always take a proper history of. We should ask the sister how much fluid we have used intraoperatively and how much fluid is there in the outlet. We should measure that. We should be very careful in patients with elderly patients, patients with comorbid conditions, especially with patients with cardiovascular and renal compromises. And this is about the fluid that the maximum fluid deficiency should be around 1000 ml for hypotonic solution and 2005 ml for isotonic solution. So as I've already spoken that we should be very careful about the patients who are elderly, patient comorbid conditions, and in some condition where there is symptoms of fluid overload, we should not hesitate to measure the serum electrolyte immediately and to give an administration of diuretics is very important. As we all know that hysteroscopy is something which we cannot do in any phase of menstruation. We usually prefer follicular phase of the cycle. Otherwise, in unpredictable menses, we can, of course, we can schedule at any time. Cervical preparation, I personally use misoprostol as like I have written in my slide also. I usually call the patient at least 8 hours NPO before the procedure. So 4 hours pre-procedure, I put the misopros for 400 microgram vaginally. And there are lots of studies who also supports that like 400 microgram or two. There are lots of studies which says we should put 200 microgram, and there are lots of studies which says we should put 400 microgram. About the anesthesia part, I think those who are doing office hysteroscope, there are many doctors who are doing office hysteroscope without anesthesia. I personally have not done any of the cases in office hysteroscope as an office procedure. I always do all my procedure under IVA, under propofol in short anesthesia. And these are some of the studies about bladder distension. They say that in order to minimize the patient's discomfort, we can ask a patient to drink around 500 ml and then to distend the bladder. Yes, this is what we have. I have spoken in the, I've spoken about it, vaginoscopy. My mind opened up when I started hysteroscopy. I was really not sure that whether is it really about the uterine cavity or it is about the cervix or either it is about the vaginoscopy. But there are lots of studies which even says that, yes, it can be used as a no-touch technique, which I have shared with you in my beginning of the talk, that once upon a time when I started doing the procedure, one of my junior told me that there's nothing in hysteroscopy, there's nothing to be done. You just have to put a speculum and hold the cervix and then insert this, insert the scope. But I personally prefer not to use any speculum. It's a no-touch technique for me also in my practice. And about the antibiotics, yes, I of course give antibiotic coverage in most of my patients because PID is very common in Nepal. About the new development techniques, there are lots of new development coming up in hysteroscope. I would also like to add up the Begetti's shaver. I've seen in many of my conferences, and it's not possible for us in Nepal to use very advanced technology and very advanced instruments because people, our patients are of low-ish socioeconomic status and they are not in a state to pay a huge amount of money. So there are lots of development which we have also seen in conferences, but it's not possible. We are using this basic hysteroscope in our practice. So we're talking about a new development. We can see this My Nature integral handheld system. We can see activated tissue removal system. One other thing which I have liked in hysteroscopic myomectomy is my dream is also do a hysteroscopic myomectomy is with Begetti's shaver. And other developments we have seen that True Clear Elite, MyoSure Omni, and resectoscope we are using. Resectoscope is like it's common. Even endometrial ablations we are doing. The endometrial ablation system which the Libreta TM has brought out, and about talking about the Minerva. This is, I think this I have never seen. I have just took out the picture. Minerva ES, the endometrial ablation device. They say that they use ionized argon gas with a silicone balloon, but I have personally, I have never seen this instrument. And yes, of course, future of hysteroscopic sterilization. We have been listening in several of our conferences that it has got several advantages over laparoscopic sterilization, which includes convenience. It is an outpatient procedure, safety, about avoiding the complications arising from the abdominal entry, and yes, of course, the general anesthesia. We all know that most of our hysteroscopic procedures are done in short anesthesia, and the most commonly applied technique to date is the issue permanent birth control system. So potential advantages, we all know that the higher this procedure gives a higher patient satisfaction and faster recovery. We all do all our hysteroscopic procedure in daycare basis, and avoidance of general anesthesia, both patient and physician convenience. Yes, less patient anxiety. Cost effectiveness, yes, we can say cost effectiveness in relation to like the patient doesn't have to stay back in hospital. He doesn't need admission. That in that reason, we can say cost effectiveness, but still, yes, in Nepal, hysteroscopy is slightly costlier because the instruments, we all know that it's very costly, and we don't get instruments. We all get the instruments from India only. So it is slightly higher in cost, and there are few doctors who are doing hysteroscopy in Nepal. It is a more efficient use of the operating room for more complex hysteroscopic cases. Yes, in my practice, we are doing endometrial polyp, we are doing hysteroscopic myomectomy, we are doing uterine septum resection, we are doing complete uterine septum resection. Yes, and of course, as I have mentioned, second trimester abortions. I have done almost 13 cases of fetal bone removal. And about the potential disadvantages, we all know that apart from this, which I have written, the instruments, they are so much breakable that like it's one-time use, and that is a little bit disadvantage because the instruments are very fragile, and it is, yes, usually they say that all the company, they say is that it is a disposable device. You can dispose after a single use, but due to patient compliance, low socioeconomic status, we usually don't you dispose the instrument like scissors, even resectoscope. We don't dispose in a single use. We re-sterilize it and we use it. So complication, yes, I would really like to include this ear and gas embolism, because in one of my conference, one of the doctors presented that the doctor has done more than 1,000 cases of hysteroscopy in her life, but it was a single case which taught her everything about ear embolism. So it is very important to teach your staffs in the OT room staffs that when they have on the flute, and when the flute is going to get over and you're going to change into another bottle, they should not pass the gas while doing the procedure. They should not pass the ear. Yes, about the perforation, we all know it is, although it is a blind insertion of the instrument, we can see very clearly. And I think hardly perforation happens these days. About fluid overload, it was more common during when we used to use monopolar, and then when you used to use isotonic fluids like mannitol. And about the hemorrhages, I think it's also very uncommon nowadays. So there are lots of like potentials in future research in hysteroscopic surgeries, as I have mentioned already, that we can we can share the patient's experience of pain scoring, acceptability. Yes, it's very important about the acceptability. We have to explain the patient very carefully, especially in Nepal. It is not only one time, we have to explain more than 10 times, because there are lots of doctors who are not doing it and they go against that. It should not be done. There is no role of hysteroscopy in any of the criteria which we have mentioned in today's talk. About the diagnosis of abnormal uterine bleeding, yes, I've already mentioned about postmenopausal bleeding, and about the treatment of intrauterine lesions like fibroid, polyps, yes, septum. It has a very good role. And yes, in reproductive problems, which I have mentioned, septa, hypoplastic uterus, I think better than the hysteroscopic correction. Sometimes we can give long, we can give a low dose of estrogen for a long period. And I have seen in many of my infertile patients, hypoplastic uterus, we have given for estrogen for more than 3 months. And those who have come with 5 centimeter, 4.5 centimeter uterus, after 3 months, it has turned out into 7.5, 8 centimeter. So we can try in that cases also. And yes, about fibroid polyps, adhesions, chronic retention of RPOC, intrauterine lesion. These are all like hysteroscopic guidance treatment is just a boon to the females of today's scenario, because we have seen in many cases septa which has not been repaired, who has gone, patients who have undergone abortion for more than 5 times, 6 times, 7 times they have done, and lots of investigation, karyotyping, aplatus, all the blood investigation, and they have done all the investigation torch, but still hysteroscopy was missing out. And then we can see after putting the scope that there is a septum, we repair it, the patient gets pregnant, the patient delivers a healthy child. So it is very important for us, even in reproductive problems. And yes, it does have a very good outcome in fertility, miscarriage, preterm delivery, yes, and intrauterine adhesions. So these are few of the references which I have taken. And thank you so much to Dr. Ritu Subedi. She has also joined with us. She is my registrar, and these slides, she has prepared it for me. So thank you so much to her also.
Thank you, Dr. Rangina, for such an excellent presentation. I hope you have cleared queries for so many of the doctors. If we have received any questions, we can take. Dr. Nishan, can you see if any questions?
Yes, ma'am. I'm checking. Delegates, if you have any queries, please post your queries in the chat box, so we can have a question and answer session. So, ma'am, give us 2 minutes. Let's check if you have any questions.
Yeah.
Yes.
Dr. Rangina?
Yes, Dr. Ritu?
Yeah. So meanwhile, Dr. Nishant is checking for the questions. Yes. I have some non-academic questions for you. That you have to answer without thinking much in a one word.
Yeah, sure.
Okay. Yeah. You are a tea or coffee person?
I'm a coffee person.
Okay. So your favorite fruit?
Mango.
Wow, mango is the season. Okay. What motivated you to become a gynecologist?
Because in my family, there are full of gynecologists. So since my childhood, I have seen only gynecologists in my family. That's the reason I have become a gynecologist.
Okay. You have visited so many places. So which is your favorite place where you have visited?
There are lots of places, but specific. I don't have any specific. I think, okay, there's a place called Mustang in Nepal. It's like there is a temple there, Muktinath temple. And like that was my lifetime experience, because it is in I don't remember the altitude, but it's one of the lifetime experience which I've had. So it is Mustang in Nepal.
Okay, great. And the place where you want to visit, where you have not visited, but your dream that you should visit that place?
There are lots of places which I want to visit, but Maldives is one of the places which I want to visit recently.
Okay. So you are doing great work for this in the field. So your message for the upcoming doctors, as Angina, we have seen a lot of doctors are not supporting to the upcoming doctors. Yes, but it's our duty, because the knowledge is always increases by sharing. So your message, as whenever we have a discussion, I think you remember we have discussed these things many times. What's your message for the upcoming doctors?
Yes. Learning is a process. And we all know that nobody is 100% perfect. We are still learning. We are also learning every day. Every new cases teach us something back. So we should be very like down to earth while learning. And yes, new advanced procedure, our juniors who are coming up, they are the future of the country. So they should learn. And soon I have already registered a company here about laparoscopic center. Soon I'll be starting training for my juniors in my center. I think in a month of 6 months. So it's very important to share our knowledge and give our knowledge to our juniors. And this is the same thing which we expect from our seniors, although we have not got it.
Okay, that's good. That's good. No, so congratulations for your upcoming this training program. So that's very good. I think Dr. Nishant has received some questions.
Yes, ma'am. We received 3 questions.
Yeah.
And one more question is from Dr. Unnati Amatya. She wants slides. I think she liked the slides.
Okay. Slides, how can I think I can send to Dr. Ritu, isn't it?
Okay, okay, no issues. No issues.
I can send it in your email and then I...
Yes.
Okay. Okay. Dr. Nishant, please take the questions.
Yes, ma'am. The first question is there is DNC, that is dilation and curettage, is same as hysteroscopy?
No, it is not same. It is a DNC. It is a blind procedure. We do it as a blind procedure. We use the curettage and then we hold the cervix with we put a speculum and then we hold the cervix with LEs or we a single tooth valsalum and then we insert the curettage and then we spread the endometrial tissue from wherever, like from anteriorly, posteriorly, and lateral walls. But in hysteroscopic guidance, what we do is we put the scope inside, we put the telescope inside the uterine cavity, and we can see if there is any abnormal growth, and then we can take that specific tissue. Although in DNC, we cannot take this specific tissue.
Okay. Ma'am, then there is the second question. What is the recovery time for a hysteroscopy procedure?
It depends upon one case to another. Like if you are doing just a uterine septum, it's like, I think even Dr. Ritu will also agree that nowadays there were days when we used to say that after doing a like uterine septum resection, we used to put IUDs. Those gone now those days because there are lots of studies coming up that we can just insert like infant catheter for 2 to 3 days and then we can remove it. Otherwise, the patient is like comfortable to work and to walk from the clinic after 2 hours. Because we are going to do the procedure in IVA, in short anesthesia, in under propofol, so the patient can go back home within 2 hours.
Yeah, very true, very true. So no specific rest is needed. Most of the patients will take a leave only for a day, the day which we are doing the procedures. From the next day, they are joining their work.
They can go back to their work.
Yes.
Then we receive also third question is what precaution should be taken care by the gynecologist or endoscopic gynecologist while performing this procedure?
About the which I have mentioned in my slides also, patient should not be having especially vaginal infection. While having vaginal infection, we should not be doing any hysteroscopic procedure. Apart from that, any specific ones like the preoperative preparation should be done nicely, like which I have told, at least 8 hours of NPO, preoperatively insertion of misoprostol, so that they sometimes in cervical stenosis, even in nullipera, it's very difficult to insert this scope. So at least misoprostol preparation will help in dilatation of the cervix. So this preoperative preparation is also very important.
Thank you, ma'am, for giving this answer for the question. Then we received one question from Dr. Unnati Amatya. Ma'am wants to know what's the ideal dose and timing of miso.
Yes, as I've mentioned, there are lots of studies who says that 200 microgram is enough, just a single tablet, or there are lots of studies who says it's 400 microgram. I personally, in my practice, I use 400 microgram 4 hours prior to the procedure.
Thank you, ma'am. Hope Dr. Unnati have got her answer. Then the last question I received is, what should a patient should avoid while going for this hysteroscopy procedure?
I think nothing specific, just that they have to come nil per oral at least for 8 hours. Other than that, I don't think. Is there anything Dr. Ritu can add up?
Sorry, I missed the question. Yeah.
Nishan can repeat. Yeah.
But there is one question that what should a patient avoid while going for the hysteroscopy procedure?
I think what Rangina has answered is correct. Yeah.
And one more question is, if a patient is previous CS 1 or 2 with AUB, can hysteroscopy be a good option?
Yes. Why not? We can reduce the pressure. We can reduce the pressure. We can reduce the flow in previous years, or whether if the patient has a previous uterine perforation history or previous 2 cesarean section with AUB, we can reduce the pressure, we can reduce the flow, but of course we can do a hysteroscopy for the patient.
Very true. Totally agreed. Yeah. But in these cases, I recommend please do the hysteroscopy in the tertiary care center if the patient is
true. Where there is a setup of ICU.
Yes. That is very important, not in the small setup. Because these days, every day we are reading one or the other thing is coming medico-legally. So in these patients, though our center is fully equipped, even though we prefer that we will do these type of cases in the tertiary care center where the facility of ICU must be there.
Very true. Yes, very true.
Yeah. So I think all the questions are over. Yeah. So thank you once again, Dr. Rangina, for sharing your knowledge with us. And thanks to my dear friend Nishant and Chitra for always having a good coordination and always providing a good platform.
Thank you.
So friends, please stay tuned us with the coming for the coming weeks. Next week we are having the pregnancy and the thyroid. Pregnancy and the thyroid. What's the correlation? How to manage? For that we are having the Dr. Abu Bakar all the way from the Cairo University. And after that, on the 12th, we are having Dr. Sharmeen Abbasi from the Bangladesh. What are the recent guidelines in the management of the endometriosis? So now from the ISHRE guidelines has been revised from 2020-22. So the recent guidelines we are going to discuss on the 12th. So please stay tuned with us. Till then, bye-bye. Good night.
Thank you so much, Dr. Ritu.
Most welcome, dear. Most welcome.
Thank you. Bye.
Thank you. Bye.